Hello everyone, my name is Elizabeth Daub and I am currently a McKendree University student studying to get my Bachelor of Science in Nursing degree. I am doing this presentation now for you as a requirement for my Nursing 470 community health class. And I just wanted to talk to you a little bit about a community health project that I was assigned to do, some of the research results that I found, the intervention plan that I enacted, and some of the results that I received. A little bit about me. I've been a nurse for 4 years. I received my associate's degree in 2012. I work as an adult ICU nurse right now in a rural community close to my home. And I look to receive my bachelor's degree here in about a week and a half. I hope to continue my education looking at nurse practitioner schools and possibly even considering my DNP. For this community health project, I was asked to observe a community health nurse in some way or form for 40 hours. I chose to observe a school nurse in a local high school. She provides school nursing responsibilities, and she also taught a health occupations class during 3 of the hours of high school class period time. So I spent 40 hours with her, and I was asked to try and find some sort of presentation that I could present to this community of sophomores, juniors, and seniors that I felt would help them in some way, shape, or form with whatever I felt they may be at risk for. I'm not really sure why, but I decided to choose to talk to them about adolescent depression and suicide. I feel that it is a very big problem, and it's something that the community itself can help to bring down the statistics that are so staggeringly high, which I found out. So this is what I decided to do my research on. So I did research on adolescent depression, and then I linked in the suicide risk for adolescents as well. So some of the information I found was that, adolescent depression is a very serious mental health disorder. It requires early detection, early treatment, so that we can prevent further harm and prevent suicide. CDC reports that suicide is the 3rd leading cause of death in 15 to 24-year-olds, which is the main group of our adolescents right now. Those are our teenagers and our college students. So it's the 3rd leading cause of death for that age group, and it's also the 6th leading cause of death in 5 to 14-year-olds, which sounds like a really young age to even be able to consider suicide as a reason to end your life, especially at that young age. But that is what the CDC has reported, and they also say that depression is one of the major predictive factors for suicide risk. CDC in 2015 reported that 16% of U.S. high school students seriously consider suicide. 13% of those create a plan, and then 8% of those report that they attempted suicide. And like I said, depression is the major risk factor for these attempts. So those are just some of the statistics that really widened my eyes into the amount of work that needs to be done to help alleviate this problem in our community. So I did further go on to do a review of literature to see what other authors and researchers are saying about this issue. Some of the things I looked at for my literature review, first I started just with the presentation and the risk of how adolescent depression presents itself and some of the risk factors that are associated with that. Clark, Jansen, Cloy, in their 2012 research, discuss a lot of the symptoms in the presentation. They discuss the diagnostic criteria for depression, and they also explain that with depression, they're more likely to experience some boredom, some hopelessness, the anhedonia, hypersomnia, weight changes, some of the things that a lot of us are familiar with. So those were all discussed in the beginning of their literature review. They also discussed the importance of the child's cognitive level when assessing them for their risk factors and the way they're presenting with their symptoms. They discussed that younger children may appear to be sad but have difficulty verbalizing their mood, and they indicate that parents are often more likely to notice external symptoms before they would notice any internal symptoms of depression, such as the depressed mood. Venta, Melick, Schatt, and Sharp in their 2014 research agreed with some of the things that Clark and colleagues had also said, stating that depression and suicide-related thoughts are highly influenced by some interpersonal factors. They explain that a dysfunctional parent-to-child relationship can be known to increase their risk of depression. Venta and their colleagues in 2014 discussed some other theories of the theory of thwarted belongingness and the attachment theory as having something to do with adolescent depression. And attachment theory, they called the idea of that interpersonal experiences with your early caregivers affect your interpersonal and emotional functioning later in life. Which would basically mean that if you don't have a good relationship with whoever that first caregiver is, whether it's a mother or a grandmother or father, if that early bond is not there, you'll have harder issues emotionally and interpersonally later on in life, which could lead to a higher risk of depression and then later on suicide risk. Thwarted belongingness is another theory that they touched on, which is the feeling of not belonging, basically. Adolescents experience thwarted belongingness due to lacking a social network or from interpersonal feelings that they just don't feel connected with their peers or with their families. And that would also increase their risk of depression and later on suicide. So after I talked about the presentation and the risk factors, I kind of wanted to just touch on some of the screening and diagnosis things that go along with adolescent depression. Lusk and Melnick in 2013 talk about how any mental disorder or neurodevelopmental disorders can cause a relationship with adolescent depression. According to them, along with Clark and their colleagues in 2012, they recommend that adolescents be screened from 12 to 18 years of age. It could lead to earlier detection and treatment of adolescent depression. So they are asking, and that was along with the United States Preventative Services Task Force as well, that screening begins at age 12 and throughout the age of 18. And that would be something done just in the primary care physician's office, that more screening does need to be done at any chance that an adolescent is seen by a physician. Effinger and Stewart in 2012 discussed the importance of providing proper screening and diagnosis. They found that the risk of major depressive disorder in adults, along with subthreshold depression, increase the risk of the presence of a suicidal ideation. They further emphasized the need to identify the population at an early age. So again, reiterating that early detection is necessary, and as soon as these kids are seen in primary care physicians' offices, they need to be screened accordingly, and they need to feel open enough to discuss those feelings of depression with their primary care physician. That was some of the screening and diagnosis that I touched on in the literature review. I also talked about the major role that substance abuse plays with adolescent depression. Substance abuse is frequently linked with adolescent depression, and its role has been widely researched. O'Brien in 2014 and her colleagues found that substance abuse disorders differentiate adolescent suicide attempters from those that are just ideators. she says that they found that multiple attempters were 5 times more likely than ideators to have a substance abuse problem. So those with substance abuse are attempting much more than those who are just having suicidal ideation. Treatment options were discussed. Psychotherapy, pharmacotherapy, or a combination of both is what everyone is most familiar with as far as treating adolescent depression. Cognitive behavioral therapy can be an effective first-line treatment for depression in teens, but there is long waiting lists to get into therapists. So there is kind of been a push for primary care to be doing more of the screening and more of some therapy options when they get to see these kids in their offices. After-school programs have been very beneficial. King, Strunk, and Sorter in 2011 found an adolescent school program which was called the Surviving the Teen Suicide Prevention and Depression Awareness Program. So it was designed specifically for teens. It was this program that was given in 4 50-minute sessions to these students, and it just discussed all of the risk factors, the symptoms. It was a very open project that allowed them to discuss their feelings, and they found great results with that. So that was my literature review over adolescent depression and suicide. With this information, I decided to speak to some of the students that I had observed over the past few weeks at their high school, and I was able to present to them what I felt to be necessary and beneficial for them to help prevent any suicidal thoughts, or to help with any depression thoughts and where they can turn to for help. So my intervention plan, I decided to make a PowerPoint presentation, and I can show you that. So the students were sophomores, juniors, and seniors. There were about 24 students in the classroom. We were actually asked, they had a field day where we got to go to a local hospital. This is something that their school nurse, their teacher, Mrs. Rittenhouse, provides for them once a year. We went to the local hospital in a nice conference room with a projector, and they had a day, a full 8-hour day filled with presenters on just anything that they felt and that their teacher felt could be beneficial for them. So I was asked to be one of the speakers. So I provided a 35-minute presentation to them on adolescent depression, and I'll just go over a little bit of what it looked like. We kind of talked about, I opened it up with just what their idea of depression was, asked them to explain to me what they knew about it. It was just a very open first conversation to see where I could gauge what they knew about depression, what symptoms they were aware of, and where they should turn to for help. All of the students were very interactive, which was amazing. They all had great stories and great questions and great answers. They were all very, very interactive. So we just kind of opened it up talking about what they knew, and then I kind of hit them with a few of the statistics, which were staggering for a lot of them. And then we talked about what to look for in the symptoms. A lot of these things that the kids were very aware of, the symptoms, feeling hopeless, feeling sad, feeling angry, insomnia. This was next on my presentation. This was a YouTube video that I found, which is this Sabrina Benaim. She does a talk or a little speech about her struggle with depression, and the students really did interact well with that. I felt like they really enjoyed that. We talked about the causes of depression. We discussed what can be done, some coping tips. We went into the treatment options, the medications, the therapy, and then hospitalization if needed. We talked about the stigma of mental health, and I related that back to how cancer once had a stigma on it and was once misunderstood. We talked about suicide after that, and some of the warning signs for suicide. And then we talked about some of the hotlines and what they can do to reach out for help. At the end of the presentation, I let them choose if they would like to take a pamphlet, which I received free from the National Institute of Mental Health website. So this was just a teen depression. You are not alone. There are ways you can feel better. And I received that from, like I said, the National Institute of Mental Health from their website. So this is just a flyer, some of the things that they can do or they can look for. Some of the resources, the hotlines are on here as well. I also gave every student the Beck's Depression Inventory survey. I left that free to them if they would like to complete on their own, which a lot of them did. I asked them that if they had questions about it, if they felt like their scores were higher than they originally thought they would have been, I asked them to either personally drop them off to someone they trusted, be it their school nurse or a family member, or friend, or teacher. They could do so anonymously or whatever they felt like they needed to do with that information. But it was just the 21 questions on the Beck inventory scale, which is here. Overall, I feel like the presentation with the high school students went very well. I was very happy with their amount of interaction. I did not supply them with a survey, which I probably wish I would have done in hindsight, just to see what they had learned and if the presentation was beneficial. I do feel like because of their level of attentiveness and interaction that they were pleased with the presentation. I could gauge their knowledge level by some of the questions I asked in the beginning of the presentation. But I do still feel like this presentation needs to be done more widely, used in the high school setting. I did ask Mrs. Rittenhouse, the school nurse, I provided her with a sample of my PowerPoint presentation and gave her free permission to use it whenever she would like to use to help spread the word about adolescent depression and the risk for suicide. Thank you very much.